Good evening. Well, my name is Joe Sam Robinson, and it's my pleasure to have with us tonight Dr. Castro,
Thanks
who
for having me.
is a man of great repute, and we're happy to have him here
Thank
in
you.
Macon, Georgia, as he goes forth to slay the demons that look after his patients or go after his patients. Well,
Correct.
welcome.
Thank you for having me again. That's the
welcome,
second time.
welcome, Igor. Well, there's a lot to talk about.
Yes.
So the world is careening along, and we're involved in spine surgery, and so we do that. And a lot of different kinds of problems appear.
Correct.
With spine injuries and spine problems, and maybe you could just discuss a little bit about trauma. Whereas I don't know if the audience knows about, we're in a grade 1 trauma center.
Yes, correct.
And so we have a lot of people that come in with different kinds of spine injuries, particularly automobile accidents, sometimes gunshot wounds, all sorts of things.
Correct.
So any comments about that? What are your observations?
You know, it's a little bittersweet, talk about trauma, because it's like the more we are modern in the put the bone together, in a sense, the spine column, put the spinal column together with the new screws, new technology. We have robot.
Right.
Dr. Roberts has a good experience with robot, this fantastic GPS navigation. We still don't have a good answer for the spinal cord itself and get traumatized.
Yes. So, yes. That's a terrible problem. We have spinal cord injuries, and we can't really redeem the situation if the spinal cord has been injured excessively, though there are lots of ideas about that, about what we could or could not do.
Correct.
Or maybe using a mechanism from the brain to send little signals down past the.
I think that will be the future, but we're far away from that, and they try, you see these people desperate because they have the young, son or daughter that was being in a car accident. They want to take them to China and inject stem cells. All that is still bogus. All that's still not there, and there's no like a clean field that they can restore the function of the spinal cord. It's pretty much like when you start the training, right? You have a devastating injury in the spinal cord, and it doesn't, choose any, it doesn't respect any economics or social, like it affects everybody. It can affect the kid of a billionaire. It can affect the person that doesn't have any money, and we don't have anything to do in the sense of restoring the function below the injury. Well, the perfect example that we have is the actor that represents Superman. When
he was in Macon in his earlier life. He here.
Christopher Reeves.
Yes.
So he had this terrible injury after a horse accident, and he was an event later after that. Doesn't matter how much money or how much prestige you have, we still don't have a good answer. But I think it's important. When you say about trauma, it's important the first assistance when the patient had the injury, that the first responder to immobilize that neck. We see how many cases we can prevent further injury. Providing the proper care at the site, proper care at transportation, and when they get to our hands. I think that's still a challenge for us, and I know you fight for. The helicopter transportation, the helipad. All that, changed the story of the spinal cord injury.
Right. So we could just discuss a little bit about in Georgia, there are 11 million people, a lot of frisky people out there. We have big highways. We have lots of accidents. And one thing that's needed, I think, is a really effective trauma system. And Dr. Ashley, who's one of our colleagues in Macon, he's the head in Georgia of the Georgia Trauma Network, and a lot of good work has been done there. Nevertheless, there are some problems about getting people that have been injured in one form or another to an appropriate tertiary care center and get their care quickly, because when these injuries take place, if there's pressure on the spinal cord, and we can relieve it soon enough, we can really redeem
restore function.
We can. That's happened. I mean, we certainly see that. And so the access to really fast intervention is an extremely important thing.
Yeah. Yeah, it's funny
Yes.
that because like you said 11 million people live in Georgia, and prior to my move to Georgia, I was in Arkansas, and the most populated city
Yes.
actually has a population less than Macon.
Really? Yeah, really.
Yeah, because Atlanta is like what 3 million people.
Well,
now?
more, 5 or 6 million.
5-6 million.
Yeah,
So you
it's
see,
it's a huge.
and the
place.
biggest city in Arkansas is Little Rock. Of course, when you move north, and you have those conglomerate of 3 or 4 cities,
Right.
because of the Walmart office and all the Tyson and JB Hunt, all those big companies there. When you put together all those 4 cities, a little bit more than Little Rock, but the city itself, Little Rock is the biggest. And Macon, that we consider here in Georgia small,
Right.
is bigger than Little Rock,
Right.
and it's bigger than Jackson, Mississippi, even. Like
Yes.
another big city in a small state. So we do a lot of work here. You're right. It's a level 1. We need to be careful. Is a lot of work. I think Dr. Ashley has this trauma program going. I think we can still help a lot of people. I think.
Right, and so we'd like to get patients in as quickly as we can. There's a lot of work going on, and it's particularly a problem, I think, in isolated places in South Georgia. So if an injury happens there, there's a long distance to get to a tertiary care center. The mechanism needs to be in place. And after we do what we can here, a recovery from a spinal cord injury is a vexing task. If we see patients, we do what we can, and then we try and get rehabilitation. And I would say the amount of resources that go into that could be increased. There could be some increase in the resources devoted to recovery from spinal cord injuries. It's really a terrible family event. The whole family is impacted. Economic events take place, and there can be all kinds of pain and difficulty after a spinal cord injury. So that is an important thing to put in place. Now, there's a lot of surgery done on the vertebral column and on the spinal cord, on the nerves that are there. I would think one of the biggest things going on is trying to do something as the spinal cord ages, as the vertebral column ages, the bones age, the density changes. So we have a lot of pressure that takes place and lots of back and leg pain, arm pain, and there are different ways of intervening for that. And I know you're on a cutting edge of a lot of issues.
I like the way, like very subtle, you change from the trauma to the wear and tear and degenerative disc disease, because I think they run parallel. You're right. You can still have wear and tear of the spine and have a trauma.
Right.
So they're not like really divide, but they're happen together. Yes. And I think there's again a big push in the world now. You look some publications from Europe mainly, because FDA here research is very strict on people trying everything they can to save a life of a disc itself. Because the bone is going to do what the disc is not doing. It's going to build more bone, create bone spurs, but basically like the disc is a part of our body with poor vascularization, poor blood supply.
Yes.
And there was a big push to inject stem cells to try to recuperate. As now, we're still not there. We don't have the technology to bring our,
that's a common thing. People
ask
all the time. What about stem cells?
Stem cells. They can inject in your knee. They can inject in your shoulder. They have those anecdotal results. But when they inject in the disc, the results nowadays is still not as different as injecting steroids. Right. So we're not there. We don't know where is the time to do it. We don't know what's the time to prevent. Some people, it's 18-year-old and have the disc worse than me and you. Right. And some people is 80-year-old and have the disc better than if somebody's 30-year-old. So we don't understand the aging, the genetics behind it. But there's a big push with stem cells. One thing that's coming back now, Dr. Roberts, that we advance on the neck instead of doing fusions, doing artificial disc. Yes. There's a big push now for people doing artificial disc in the lumbar spine. Yes. Young people, fit people, they don't want a fusion. That's a little bit more complicated because go from the front of the abdomen for people that's, not too familiar for the surgery we do. It's like the the approach is crucial,
Yes,
especially in a man.
right.
You have so many structures there, vessels.
Right.
The complications are not simple. So
Yes, right.
there's a lot of things going on, but slowly we're getting better results. I think the main thing is decrease the complications. You know,
Right.
some, like you tell me all the time, some people does not need surgery.
Right, right.
You know, if they can lose weight, engage in a better exercise routine. I mean, you do your part. You eat well a couple times a year. You go to do your hiking.
Right.
I see you taking the stairs.
Right.
You know, we kind of neglect a little bit that, you know,
Right.
to ourselves.
Right.
That exercise is crucial, that you cannot load yourself in sugar all the time.
Right.
Soda, carbs. I think the spine paid the price of our bad habits.
So, you know, one of the, I think, things I've observed are the new medications that have come into existence to help with obesity. Now, many people arrive in America, they go to the airport, they say, oh, wow, look at all those tubby people.
Somebody just get arrested in Brazil with $350,000 in Monjaro.
Oh,
I have
really?
to show a picture. I'll show you
Oh,
later.
okay. Well, so people are, they eat a lot here, and compared with other countries, we have a lot of obesity. And what happens when this occurs, when a person starts to carry around an extra 100 pounds, it puts a lot of stress on joints, knees, all the joints, and the vertebral column. And as the body responds to the additional weight bearing, the joints in the bones in the vertebral column hypertrophy, and as they are hypertrophy, they put pressure on nerves. The size of the canal diminishes, and so that really puts a person in a bad situation.
Correct.
If their vertebral column has been injured by obesity, then it's hard to, from our purposes, totally restore its
And
function.
like you said, it's a vicious circle. So now that he's overweight, that he needs to lose weight, he hurts more.
Yes.
He hurts more, he doesn't want to exercise.
Right.
He doesn't want to exercise, he gains more weight. So it's a vicious circle that we have somehow to interrupt. Sometimes surgery helps,
Right.
sometimes conservative treatment helps. We all start conservative treatment first, steroids, NSAIDs, diet, physical therapy, water therapy, I mean, anything we can do it. But I think water therapy is great for people that's overweight. You still can
Yes.
burn some calories,
Right.
protect your knee. Because another thing that we didn't discuss tonight, and it's very important, it's fall from the the height.
Yes. Right.
You know, the older we get, our balance is not the same.
Right.
So people neglect that our vision deteriorate, our hearing deteriorate, but the vestibular also deteriorate.
Right.
Our balance is not the same. Once you get old, you fall more, and you're gonna hurt yourself when there is fall. Imagine that falling from your height, and now instead of weighting the proper weight,
Right.
you're 100 pounds heavier, like I said.
Right. And,
So-
and that, I think you bring up a good point here. If you look at the injuries we see, a surprising number of people, elderly people, have tripped and they've maybe fall on the way to the bathroom. They wake up to void in the middle of the night
Correct.
and they trip.
All the time. We hear
Right,
to that
right.
all the time.
And so it's important, I think, for older people to be cautious about the way they move around. The locomotion issues have to be really, really careful. And I think use banisters. That's the one thing I could say. And I'll just make a comment. I have a friend, a wife of one of my friends in New York City, and she's a very particular lady. And she doesn't like to use banisters because of the germ problem.
Okay.
So if she has her hand on the banister, she's concerned these might be.
So
So she's going
germaphobe.
down, not using banisters. Well, it's a risk-benefit ratio. It's true enough. You might get some idle germs. You may
just wash your hands,
but
or
if
keep
you're
like a
that's
little
right.
alcohol in
If
the
you're
pocket.
an older person, you have to be extremely careful.
Yeah.
And alcohol plays a role in this whole arrangement too. If people they have a few drinks and they fall as they.
Correct. You know, we have a meeting coming together in May that, you know, the place that you love. We're going to go again in Portugal because we have a good relationship with the chief of spine surgery at
Yeah,
Porto,
right,
big city, second biggest city in Portugal.
Right.
So he invited us to be there in May. But one of the meetings, I don't think you remember, I think we went to Rio, the big orthopedic hospital.
Right. Yes.
And in the middle of the meeting, I asked this Japanese neurosurgeon, I think he was from maybe Osaka. And I asked
Yes.
him, so like, what's this thing about falling? Because your population maybe be older than ours.
Right. Yeah.
They're centenary.
Right.
And he said, it's so funny because we had this discussion in Europe last year, and you see all these Japanese people in the park, and they make fun of them doing
Right.
the
Oh yeah, they do. They
Tashishuan, whatever they call it,
whatever.
and they do very slowly, 1 feet, 1 leg. That actually is a good prevention. They're actually exercising their limber,
Right.
exercising their vestibular, and I think this is very important.
Yes.
No matter how old we get, we have to go out there and exercise.
Right.
Yeah, and of course you love hiking, but there is indoor activity you can do to improve your balance.
Right.
But the most important, like keep your house, lean. Take the carpets. Don't step on the pad.
Right,
Just be
right,
careful with
right.
all those things around you, because once you fall, we don't know the damage it can
right,
cause.
right.
Yeah, prevention.
I think that's a big point about people as they proceed through life. They imagine they're 21 years old still. I mean, and actually they're not.
Yeah.
You have to be pretty restrained about your activities, and I think that would be a good thing to get into now. Artificial disc. We could maybe talk about the neck doing artificial. We occasionally see people that say, "I have one."
Yeah.
Can you comment on that?
So the artificial disc, the company that really push for the solidification. I mean, big companies before try, and they're all coming from Europe first.
Right.
The whatever the name was back in the day. But this big company in France is called LDR, get sold by and bought by an American company. And now they're in Austin, Texas. But when they launched several years ago, 20 years ago, the main thing was they knew to the get-go is more effective in the neck than in the back.
Yes.
They knew it.
Right.
They didn't know why.
Right.
And the explanation came later, like you just told about the hypertrophic facet.
Right.
Lumbar spine, I think the axial load, because your whole body is a lot more.
A lot of weight there. Right.
A lot of weight. The neck is mobile, but there's no, our head weight doesn't compare to the torso weight. So the ratio in the beginning when these people LDR, and I think the main hospital was putting those discs was in Strasbourg, Professor Steib, orthopedic spine surgeon. He said the ratio was like 90 neck artificial disc for 10 in the lower back.
Yes, right, yes.
And I think the ratio is still kind of like that. And this morning I saw a patient and I told him about not really artificial disc, but for anterior approach.
Yes.
As soon as you talk to them, no, I don't want anybody to go for my belly.
Right,
so we still have the stigma with males.
Right.
They don't want sexual complications.
Well, that could be an important complication, could it not?
Yeah, like somebody young that wants to have kids, 1% of what we call retrograde ejaculation is not a big deal until the 1% is you.
That's correct.
Once the 1% is you,
there's some sensitive anatomy.
Big vessels there. That's not like in the neck that you can control a carotid bleeding compared to the vena cava bleeding. So artificial disc, I think, is still very tricky.
Right.
I think there is a role for young people. You see those young men, 20 or 30. We just have a single level completely degenerate, and the rest of the spine is great. I think those are a good candidate. You have to have a very good, especially in the States, a good access surgeon. I don't encourage any spine surgeon to.
Right, it's a team approach.
It's a team approach. I wouldn't like me and you try to learn now how to get in somebody's belly and exactly. Been a while, and I don't like to deal with a vena cava and and iliac vessels down there. So I think you're right. And you've done in other areas. You've done pituitary tumor for ENT doctor, which is delightful. They just put you down there. You can see everything, the technology with the optic. I think it's the same thing with the artificial disc. Of course, in the neck, for us, we do arteriocervical fusion. It's not a big deal. We can be the surgeons doing the approach and doing the procedure. So I think there's a big role. My experience, like the patients that do the best for me is the one that have strong necks.
Yes.
Wrestlers, fighters, they do very well. People with no good muscle, they don't do it as well. For some reason,
So one of the issues we confront in spine surgery is if a common thing that happens, some kind of fusion occurs anywhere in the vertebral column. So, and there are good reasons to do that. But one of the difficulties is that when we do this, we change the the geography of the vertebral column, and so the weight bearing is transferred to another place.
Correct.
So it's common to have a problem below, above, and then occasionally below wherever the fusion
Correct.
took place. And supposedly, one of the advantages in the neck of the artificial disc is that there's less of that problem. So the artificial disc is going to work better to prevent this hypertrophy at
Correct.
other levels. Is that a fair
It's
statement?
correct. It's correct. And you still see, like, they distribute the load and not stabilize
Right.
that level, so it doesn't put pressure above and below, what we call adjacency level disease. But we still see that disc made by God is way better than the made by man.
That's right.
So we still see ossification, what they call heterotopic ossification, after you put artificial disc. I have a lady now that she has one level done.
Yes.
She didn't do well. She has a lot of osteophyte covering that disc, so we have to go ahead and do a fusion.
Right.
So we try, we
Right,
try.
right.
It's not perfect. It's getting better.
Right.
And it's better definitely than what we had before. I remember many years ago, and you talked to him in Brazil, Professor Sami has a series of, if I'm not mistaken, 2,000 people that he just took the disc
Right.
and put plastic, methyl methacrylate.
Oh, did he? It's
So,
we
you
might,
know, like,
right. We
wasn't,
might,
yeah.
that's good. We might comment about Professor Sami. It's interesting. He's an Iranian guy. He's a world famous.
Brilliant, yeah.
And he has a institute in Germany, and it's shaped like a brain. So he had an architect that created
The neck and the brain.
a brain,
yeah.
right.
In
So
Hanover.
you go into this.
Apparently he has another one, I don't know if it's the same anatomy of the institute, but they have another one in China, some
really?
institute, and in Tehran.
Yeah, I know he's Iranian, right? It's a big guy there. Well, we have a lot of adventures with the vertebral column. What we don't see too much now is tuberculosis of the.
Correct.
Now, in Brazil, did you see some
I
of
saw
that?
in graduation, so we doing in the internal meds rotation, the rotation that we rotate the most because they need us, was pulmonologists.
Yes.
So we rotate a lot, and we saw everybody on triple antibiotics.
Right.
I think back in the day, rifampin, isoniazid, and pyramid. I mean, it was 3 antibiotics.
Right.
And they have to be on treatment sometimes for 6 months for the lung disease, but 9 months for the bone disease.
Right.
So again, for under care areas or for the rural area in Brazil, there was still a lot of tuberculosis. The big difference, I think, in Brazil is was mandatory the vaccine.
Oh, really?
The vaccine did not avoid you to have the bone tuberculosis, but just for the meningitis, form. But we had a bunch. The AIDS brought back some.
AIDS, yes.
But not in the 50s and the 60s when they have epidemic was POTS disease, right? POTTS, POTS disease. But there was a lot, but I don't think I don't see anymore. I mean, when they show cases and all that.
There's an interesting book out. I think it's called "The War Outside My Window," which a rather tragic story about in Macon on College Street. There was a young boy who had juvenile osseous tuberculosis, so he had POTS disease, and there wasn't much that could be done. And he was keeping a diary. It's a very powerful book, and
almost like Anne Frank.
Exactly right. Exactly like Anne Frank is suffering. The war was going on, and his family tried everything they could to save him. And he died. I'd say he was maybe 13 years old, and it really brings up the thought about all the terrible suffering the humanity has experienced in many ways. So we don't think much about tuberculosis.
We don't. And there's another book. I think what they made us read. It was a difficult book to read. I think it's The Magic Mountain.
Oh, right. Thomas Mann, about a tuberculosis
sanatorium. When they made us read it.
Did they? Well, I think that's a rather famous book. I'm trying to think. In that book,
I can't remember what country it was.
It was in Switzerland. He was German, and then he fled the Nazis, and then I believe he won the Nobel Prize, and he
the Magic Mountain.
Right. It's about about where the tuberculosis sanatorium was located, and I think that when they have the big meeting in Switzerland, where does everybody go? The World They have everybody once a year. They
Oh,
go.
Davos.
That's a former TV sanitarium. That's so everybody, and they thought, well, let's go to the mountains
to cure the air,
to help
the pure
that.
air, yeah.
So it's a terrible tragedy. Yes, and I think in that book I'll reminisce slightly that there was one patient had hydrocephalus.
Oh, really? I don't remember.
Right, and I think they operated by just removing part of his skull, which wasn't a good idea. Everything pushed through there. Well, I don't know. They make that little vignette,
Yeah.
and this I think was taking place in the 1930s.
Yeah,
so,
1930. I remember it was pre-war.
Yeah. Well, that's interesting that you read it. Well, okay, we both read that book. Well, we have some more issues with vertebral column.
Yeah, but going back to your point, we don't see the chronic infection anymore, but I want you to comment on that.
Yes.
We see more and more of the acute infection.
Right, yes.
The bacterial, what we call osteomyelitis.
Right, yes. We see a lot of it.
A lot of that. And I think I have my theories that our immune system is being compromised by our diet and by all the habits.
Right.
But you see a lot in renal patients.
Right, yes.
Right? Patients go to
right.
dialysis.
It's a real problem.
It's a real problem. And my theory, I think, I was talking to somebody at GNI, I think there's impossible to sterilize that circuit when they go to get the IV and get the blood to be filtered in that machine. There's two issues. We see them bleed because they have to heparinize, put the heparin there, and who knows the doses in there in those ducts. And the second problem, like how that thing can be sterile, is almost impossible.
Right.
So I think the person that be exposed to that 3 times a week has a great chance to put in his system
That's right.
germs, and then we see all the time, which is sad because most of the time they're non-surgical patients.
Yes.
But they require us to look, and you have to put those patients in 6 to 8 weeks or more antibiotics.
Right.
So it's a devastating thing.
Yes, and so a few comments about infections. The immune system is sort of out of our field, I'd say that, but we certainly pay some attention to it. I don't think we know exactly, there's not a number on how good your immune system is, and that's a really big deal for infection and also for cancer.
Correct.
So if you anything you do to weaken your body habitus predisposes you to all kinds of things. So if you let your sugar get out of control, you're diabetic, that's going to predispose you to problems, and also cancer. So it's interesting that a fact that stayed with me from medical school is the pathologists were chopping up organs or looking at organs, and so the prostate, here's the prostate, and see these little niduses of cancer. And the pathologist said, and it stayed with me, that if you have a 1% for every year of your life, if you're a male, you add the chances of having prostate cancer by 1%. So if you're 90 years old, 90% chance. If you're 100%. If you're 50, but your immune system just takes care of it. Yeah. So the little cells are floating around. And
I think the goal is try to push as long as you can for being less aggressive.
Right. But the immune system plays a major role in our health and welfare. I'm getting a signal I can't quite see there, but I think it's probably getting about time to conclude. Well, it's been great having you here.
Thank you so much.
It's great having you in Macon,
very
Georgia.
good chat.
Yeah, it's good. And let's together go forward and do our best to help our patients.
Correct. Thank you so much,
Dr.
Thank you for having me.
Thank you for being
Take
here.
it.
Thank you. Thanks.